Neuropatho key terms is the next topic, so please be sure to write these down. First up is vegetative state. There's brainstem damage, so there's loss of awareness and mental capabilities. And since the brainstem plays a big part in controlling the heart rate and respiratory rate, clients will typically have to go on life support, or a ventilator may be needed to help the client breathe. The next key term is brain death, diagnosed with a flat EEG, an electroencephalography. This is a test that detects abnormalities in brain waves, or in electrical activity of the brain, commonly used to diagnose the severity of chronic seizures, which we cover in detail in a separate video. So with brain death, there's no brainstem reflexes, and also no spontaneous respirations. And this type of death must be evaluated twice by different providers. Okay, the next key term is locked-in syndrome. The client is paralyzed, but thinking is not affected, and they cannot communicate. The next term is a really big one here, so I'd be sure to pay attention. Level of consciousness. So we have the acronym AVPU. A is for alert or awake. V is for responsive only to verbal stimuli. P is for responsive only to painful stimuli. And U is for unresponsive or unarousable, also not awake. Now O is for orientation or oriented. Clients will typically be asked 4 different questions. For example, person, place, time, and situation. If the client knows all 4, then they're oriented times 4. Now ALOC is altered level of consciousness. This is also called a change in mental status and mental status changes. Now lastly is the GCS, the Glasgow Coma Scale. This scale is used objectively to describe the extent of impaired consciousness in all types of clients, from acute medical to even trauma clients. The scale assesses the clients according to 3 different aspects of responsiveness. For example, eye-opening, motor reflexes, and even verbal responses. So let's play a short segment right now. Now, switching gears here, let's talk about the GCS. This is used to measure level of consciousness, and remember, the earliest sign of that increased ICP was that mental status change. So let's break down the GCS score real quick. So a score of 15 is the highest score. This means that the patient is fully conscious. So we like high scores here. As ICP goes up, the GCS goes down. So the key number here to know is less than 8, we must intubate, since these clients are in a coma. Basically, the ICP is getting so bad that the brainstem is being herniated, basically crushed, crushing the drive to breathe and the heart rate. And the patient obviously slips into that coma. So the priority here is to notify the provider immediately for any GCS numbers that are decreasing. They should not be decreasing, they should only be increasing here. So the HESI mentions a scenario of a GCS of 7, stating that the patient will require complete care because they're in a coma. So remember, less than 8, we intubate because they're in a coma. And a common NCLEX question talks about a client recovering from a head trauma with a GCS of 14 over 2 hours ago, but now the GCS score is 11. Guys, we must report this to the HCP immediately. Again, any decrease in GCS is priority to report. Now, there was an interesting question from Kaplan here, stating that a client with a traumatic brain injury and increased ICP with a GCS of 5, why is it important to provide eye care? And the answer was to prevent corneal irritation. So remember, let's break this down here. GCS of 5 is less than 8, so the client will be in a coma, and clients in comas may have eyes open. So we want to prevent that corneal irritation. Now, we did see 2 questions talking about alertness in terms of spontaneously alert, that alert without stimuli, and orientation, basically seeing if the client's confused. So the HESI mentions a patient replies with the correct name and location, but incorrect year and date. How should the nurse document this patient's response? And the correct answer was alert and oriented to person and place. Now, another common NCLEX question here is which assessment best demonstrates the GCS? So painful stimuli that is applied and the patient pulls away
This is responsive to pain. And a client responds to a nurse's question. This is responsive to verbal. So don't let the NCLEX trick you here. Again, this is not spontaneous since these clients are responding to a stimuli. So responding to the pain or responding to the verbal cue.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.
Alzheimer's disease is all about the brain damage. It's a non-curable progressive disease where plaques build up in the neurosynapses of the brain, disrupting brain signaling, which seriously impairs memory and personality changes. It's considered the most common cause of dementia, a general term for brain damage that results in decline of mental ability. So just think dementia is damage to the brain.
Now for some patho test tips here. We also see 3 unique characteristics. Number 1, amyloid plaques. Number 2, acetylcholine deficit. And number 3, neurofibrillary tangles. This is abnormal accumulation of a protein that collects inside the neurons. So I'd be sure to pause the screen and write these 3 down, as they love to show up on patho exams.
Now, as far as risk factors and causes, the development is related to a combination of genetics, lifestyle, and environmental factors. So the number 1 risk factor on many question banks is a family history of Alzheimer's disease. Children of parents with early onset Alzheimer's have a 50% chance of developing the disease. Now, most students get this wrong on various question banks. And regular exercise can reduce the risk of Alzheimer's, as mentioned by another question bank. But healthy lifestyle choices like smoking cessation, avoiding excess alcohol, and regular exercise were shown to decrease the risk. Now, don't let the NCLEX trick you here by telling a client not to worry about it since there's nothing they can do to prevent it. That's completely wrong here. There's a lot of lifestyle changes that we can do to prevent those risk factors. Now, as far as signs and symptoms, just think of the patho here. Alzheimer's is all about the brain damage, resulting in problems with judgment, change in personality, and loss of memory.
Now, other common manifestations for patho exams. Number 1, we see irritability and hostility with anger. Number 2 is mood swings. And number 3 is gradual memory loss. The inability to recognize family has shown up on a few different question banks, so please be sure to write that one down. And number 4 is a lack of environmental awareness. Clients will commonly wander from their home and get lost, not being able to find their way back or even recall familiar surroundings. Now, books will outline 3 to 7 stages of Alzheimer's, but to keep it really simple, here are the common stages.
So, stage 1, we have no impairment. Stage 2, you start getting forgetfulness and short-term memory loss. Stage 3 is that long-term memory loss, where you start forgetting names and actually start getting lost. And then stage 4 is bedridden with uncontrolled bowels and urine, paralysis, as well as a common cause of death is infection related to pneumonia. But again, the stages of Alzheimer's are nice to knows and not technically a need to know on most question banks. Now, interventions are a need to know. So education for the family and caregivers are always the number 1 most tested on quiz banks to help keep the patient safe. So instead of memorizing all these lists, always think about the patho here. Alzheimer's, we have a very confused, forgetful patient who lacks judgment, meaning a high risk of getting lost and even fall risk. Again, it's kind of like taking care of a 2-year-old, so we need to keep a close eye on them. So the number 1 thing is fall safety. Key terms here: remove throw rugs and clutter from the floor. Number 2, grab bars are installed inside the shower and tubs. And number 3, a night light and well-lit halls to prevent falls and help orient the confused client. Now, don't let the NCLEX trick you here. We do not provide a dark room or environment for sleeping. We need well-lit night lights here to prevent falls. Now, secondly, for location and lockdown to prevent wandering and getting lost. So the biggest key term here is a safe return bracelet on the wrist. Number 2, we lock doors that can lead to safety risks. So stairwell doors can lead to a fall risk, must be locked, and key deadbolt doors leading to the outside. Patients can get easily lost. And the last 2, we lock hazards like toxic chemicals, gas, and even sharp objects. And medications have to be locked and out of reach. Once again, don't let the NCLEX trick you here. Medications are not to be placed in a pill dispenser. Many students get this wrong. So just think, always lock it down with Alzheimer's. Now for living areas, we always allow for free movement, that's a key term, so move furniture appropriately. And place frequently used items within reach, another big key term there. And then lastly, pictures or symbols to label commonly used doors or devices. For example, a picture of a toilet on bathroom doors, and label hot versus cold water. Now in terms of communication, we want to keep it simple. Remember, we have brain damage resulting in this dementia here. So the big no-nos, no open-ended questions, we need yes or no questions. Remember, keep it simple. And not too many options here, limit the choices. And then do not rush the client. Allow plenty of time to complete ADLs and other tasks. This will help decrease anxiety by decreasing the number of choices and being patient. So ATI mentions a scenario where you create outfits and allow the client to choose one each day. And ATI also mentioned that you have to treat the client as an adult, not like a child. Yes, even though the client will act like a 2-year-old with a childlike affect, we must remain patient and treat the client as an adult. Now for the tricky questions on the exams, write this down here. Agitated clients with Alzheimer's, or even those with dementia. We always, number 1, acknowledge and discuss feelings. Number 2, this is a big one here, redirect with new activities. Big NCLEX tip. And number 3, a big no-no. Do not present reality or rationalize. Guys, write that down. Very tricky questions come from here. We always redirect any agitated client with Alzheimer's, or even those with other types of dementia. Remember, these clients have damage to the brain, preventing them from understanding reality. So presenting reality or rationalizing with them has been shown to cause more anxiety and more agitation. That's why distraction is the key term there, and redirection to new activities is the best choice on the NCLEX and nursing exams. So even HESI mentions a stage 3 client with aggression, we complete crossword puzzles. That distraction and redirection there. And a common NCLEX question asks, the best nursing action for a client with Alzheimer's who is frustrated, stating they're waiting for their husband to pick them up, but their spouse has been dead for over 10 years now. The correct answer is to acknowledge their feelings, and then the key term, redirect with new activities. That's the correct option here. The worst thing you can do on the NCLEX is say that your husband's dead and present reality. No, do not present reality here. That's typically wrong on nearly every question bank. Always redirect. Now for diet, it's common for clients to forget that they've recently eaten. So the best approach is for caregivers to give the client something when they say they're hungry. But here's the catch, not a full new meal. Common NCLEX questions have a patient that states, I'm hungry, you didn't feed me. But the correct nursing action here is to give half the sandwich initially and then the other half later. Now, don't let the NCLEX trick you here. We do not give a gentle reminder that the client has already eaten. This is presenting reality. And this was the most commonly chosen wrong answer. So I'm telling you, these questions are super tricky. So just remember, redirect and don't present reality. Now, as far as pharmacology, remember there's no cure for Alzheimer's disease, but the number 1 drug to know is donepezil, which helps with memory and treats confusion. So let's play this segment from our pharmacology master course. Kaplan states donepezil is used to treat confusion in patients with Alzheimer's, and a priority finding to write down is dyspnea, which could indicate bronchoconstriction. So we must report this to the HCP immediately. Remember, the ABCs always come first: airway, breathing, and then circulation. All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides. ALS, amyotrophic lateral sclerosis, also called Lou Gehrig's disease, is a deterioration of the motor neurons in the brain and spinal cord, resulting in progressive total body paralysis, eventually leading to death in about 3 to 5 years from respiratory paralysis. Now, the memory trick for ALS, just think ALS like advanced life support, since clients will eventually have to go on a ventilator to keep them alive. Now, this is a very, very sad disease because cognitive function is not impacted. Clients can still think and are still fully aware of everything that's happening to them. It's kind of like they're trapped in their own body as it begins to shut down. Now, for the signs and symptoms, we have progressive muscle weakness, not a resting tremor. That's with Parkinson's disease. So just think ALS, we have all the muscles stopping over time. And then we have dyspnea, that difficulty breathing, and dysphagia, that difficulty swallowing, as mentioned by the HESI, and dysphasia, that difficulty speaking. So try not to get confused with the G's and the S's there. Now, as far as the GI, we get constipation and not diarrhea. Again, think ALS, all the muscles stop, eventually stopping the diaphragm muscle under the lungs, which leads to respiratory failure, our number one priority. So write that down. So ATI mentions a priority finding with a client with ALS, increased respiratory secretions. And HESI mentions an expected finding with ALS is limb weakness. As far as treatments, we can use pharmacology like Riluzole, which slows down the progression and extends life, but only for a few months. But this was not mentioned by any of the major question banks. Now, as far as nursing care, airway and breathing are always the number one priority here. So the clients will typically be on a ventilator in the end stages. So infection is huge. So we monitor for pneumonia, and key terms to write down: fever, temperature over 100.3, and lung sounds that are rhonchi. So rhonchi are just low mucus gurgling that kind of sounds like low-pitched snore, kind of like this. So think rhonchi is a really bad infection with tons of mucus. Now, not to be confused with crackles, that's typical of pulmonary edema, fancy words for fluid in the lungs, like with clients in heart failure who have heavy fluid. And it sounds kind of like a snorkel, so like this. And since we're on lung sounds, it's not wheezing, that's typically asthma. So typically asthmatic patients have bronchoconstriction, those narrowed windpipes during asthma attacks, sounding like a rubbing of a squeaky balloon, kind of like this.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for brain tumors. A brain tumor is a mass or growth of abnormal cells inside the brain. Some brain tumors are benign, which are non-cancerous, and some brain tumors are malignant, which means cancerous. So you don't want to have the malignant ones. Now for primary malignant brain tumors, it's very invasive and very difficult to remove, often unoperable. Now for the causes or etiology, a prenatal exposure to carcinogens and embryonic development is a main cause. And for adults, typically we don't know predisposing factors. Now for manifestations or signs and symptoms, it all really stems from increased ICP, that increased pressure inside the brain. So number one, we're going to see seizures. Number two, we're going to see signs and symptoms of increased ICP. For example, headache, vomiting, and mental status changes, or a change in mental status, as most textbooks like to say. And lastly, number three, this is a big one, death before general signs and symptoms, those manifestations.
So we'll see this 1, 2, and 3 progression when a client has a severe brain tumor.
All right, that wraps it up. Thank you so much for watching, classmate, and even your instructor. Now for physiology. We have the CNS versus the PNS. So the CNS is our central nervous system, made up of the brain and spinal cord. Now, the most important part to know for med-surg and pharmacology exams is the brainstem. This guy helps to control the heart rate and respiratory rate. So when we give drugs like CNS depressants, like opioids and benzos, they depress this CNS, making the heart rate low and slow. Now on the other side, we have the PNS, the peripheral nervous system, which is made up of a bunch of nerves that sort of branch off from the spinal cord and extend to all parts of the body. Now the PNS controls the somatic nervous system and the autonomic nervous system, which we'll be covering in a moment. So to help you organize this all in your brain, write down this nifty chart. As you can see, the nervous system is this big umbrella term for the CNS, our central nervous system, and the PNS, our peripheral nervous system. And as stated before, from this PNS branches off the autonomic nervous system and the somatic nervous system. Now, out of all these, the one to focus on is the autonomic nervous system, since it's the most tested. This guy controls the SNS, our sympathetic nervous system, which controls our fight and flight response. So just think the SNS is our stress nervous system that speeds up the vital signs, specifically the heart rate and blood pressure, in order to fight and flight with stress. And on the other side, the PNS, the parasympathetic nervous system, controls our rest and digest. Think PNS as our poop nervous system that sort of puts the brakes on the vital signs, slowing down both the heart rate and blood pressure. So just think rest and digest. Now, don't get confused with both PNSs here. We have the peripheral nervous system, which is the overarching umbrella, and also the PNS with the parasympathetic nervous system. So let's start with wrapping up the somatic nervous system, and then we'll break down the autonomic.
Think S for sensations for somatic nervous system, like feeling something hot or even voluntary motor movements, like picking your nose. So when we perform neurochecks, we assess the motor function with grips, pushes, and pulls, and also for sensation with somatic nervous system. And for the autonomic nervous system, this one is the one to know for pharmacology exams. So guys, focus on this. This autonomic nervous system is kind of like auto for a car. We have a gas pedal that tells vital signs to go, and brakes that tell the vital signs to slow. So the SNS, our sympathetic nervous system, is the gas that speeds up the vital signs with our SNS, telling that body to go with the fight and flight. And the PNS, our parasympathetic nervous system, pumps the brakes, telling the body to slow, and basically to relax and rest and digest with the PNS. Now, normally they work together to balance each other out. Here's the big key focus. Exams love to test on this, so write this down. The SNS I call our stress nervous system, used in survival mode, like running from a bear or fighting an alligator. The body is filled with adrenaline, that catecholamine. Now, another name for adrenaline is epinephrine. So think catecholamines, we get cat-like responses. We get constriction in the blood vessels that push the vital signs up and help the body to react in survival mode. Now, the two catecholamines to know is epinephrine and norepi. These guys help constrict the blood vessels to bump those vital signs up. And in result, we speed up the vital signs, increasing the heart rate, BP, and respiratory function. So naturally, we get a high and dry body, high blood pressure, high heart rate, and big lungs from bronchodilation to breathe more effectively, and dilated pupils to see better like when running from that bear, and a really dry body since the PNS is turned off. You really don't need to be resting or digesting when you're running for your life. Now, for pharmacology exams, the terms to know are sympathomimetic and parasympathomimetic. The Those are just nicknames talking about the drugs that agonize or basically stimulate a response from the particular nervous system. So for sympathomimetic, these are drugs that mimic a sympathetic response. In fancier words, they just stimulate the SNS to speed up the vital signs. So drugs like albuterol or beta-2 agonists stimulate the SNS response to dilate the lungs in our clients with asthma who have tight lungs. But a common side effect is a racing heart rate too, since the SNS is speeding up the vitals. And even with our clients with low blood pressure, like those in shock or even cardiac arrest, we want to stimulate that SNS to speed up those vitals. So we give epi and norepi, our main sympathomimetics, which help to vasoconstrict those peripheral vessels to increase the blood pressure and push more blood toward the vital organs. Now, on the other side of things, the PNS, the parasympathetic nervous system, is the exact opposite, since the PNS pumps the brakes on the vitals. So think PNS is our poop nervous system, since it controls the rest and digest organs. Now think, it makes everything low and liquidy. Low blood pressure, low heart rate, low respiratory rate, everything is nice and relaxed, with liquidy secretions in the mouth and bell. Hence the name rest and digest. So it's easy to think that a parasympathomimetic acts to increase this rest and digest, this PNS poop nervous system. So clients in myasthenia gravis, that neurodisease, just think dryasthenia gravis, a very dry body due to lack of secretions because we have lack of acetylcholine, which makes secretions. So we give a parasympathomimetic, like a cholinergic drug, to increase that secretion. These drugs end in stigmine, like neostigmine. So just think the S in stigmine increase the secretions for stigmines. Now, a little side note for cholinergic versus anticholinergics. Always pharmacology exam favorites. So just think cholinergic effects, we get more secretions by turning on the PNS from the production of acetylcholine. Now, anytime you hear cholinergic crisis, just think secretion crisis. Way too much fluid. Or if you hear a cholinergic drug, just think more secretions with cholinergics. Now, on the opposite side, when you hear anticholinergics, just think anti-secretions. We're turning off the PNS to turn on that SNS to speed up the heart rate. So drugs like atropine is our anticholinergic. It makes the heart rate go crazy high, like on top of a pine tree with atropine. But it also makes the body really dry. So just think you can't pee with atropine. And the respiratory drug, ipratropium, brand name Atrovent, is another anticholinergic. It makes the body crazy dry. This drug ends in tropium. So just think you can't pee with tropium. And it makes the heart rate go crazy high as well, since again, it's turning off the PNS, and in result, the SNS is turned on in full force.
All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides.
Dementia versus delirium. So for dementia, think damage to the brain that is irreversible, with long-term onset of confusion. This is seen in patients with Alzheimer's, Parkinson's, and even traumatic brain injuries, where we get multiple concussions, like with NFL players. This can cause damage leading to that dementia. Now for delirium, just think the L's for limited. It's short-term confusion that is easily reversible. And it's limited to the causes here. So once you correct the cause, you correct the delirium. Now the top two common causes are infection and hypoxia. So with infection, think sepsis. Very common in our elderly clients with UTIs. That infection travels to the brain and it turns sweet little grandma into a totally different person in a matter of hours. So the key terms to watch out for is temperature over 100.3 and urine cultures that are positive. This is indicative of a UTI. Now for hypoxia, that low SpO2, Just think low oxygen. So one of the earliest signs is mental status change, and the key word that's typically used on most question banks is agitation, due to that low oxygen in the brain. Now, a commonly missed question is typically that of a combative person who is confused after major surgery. So the priority action is to assess the client. Guys, assessment always comes first on the NCLEX and nursing exams. So don't let the NCLEX trick you here. Don't assume that the patient has dementia. Always assess first. And don't assume that the patient is angry with the care. Remember, never assume, always assess. Now, the other causes, we have opioid pain meds that can make the brain low and slow with hydromorphone and morphine. Just look for the O's in the opioids. As well as low sodium, below 135, and low blood glucose, below 70. Just think hypoglycemia is below 70. So we say hypogly, the brain will die. Now, a common NCLEX question asks, the nurse understands which factors can cause delirium. Remember, look for the L's because it's very limited to the causes here. So select all that apply. So option number 1 and 2 are correct here. So positive urine culture with a high temperature, most definitely an infection. And option 2, serum sodium level of 123, yes, below 135 is not good. That's indicative of hyponatremia. Now option 3, serum blood glucose of 120. No, that's actually a good range. So we only get low sugar below 70. That hypogly, the brain will die below 70 here. Now option 4, SpO2 of 82%. Yes, that's hypoxia. And option 5, that brain damage is incorrect here. Remember, we're limited to the causes for delirium. And remember, dementia is that damage. Now, as far as the treatments for dementia, that brain damage, remember, there's no cure here. Only care for the client's disorientation and prevent anxiety and agitation. So the keyword to write down is agitated with dementia. This is always the trickiest questions. So write these down. We, number 1, acknowledge and discuss feelings. Number 2, a big one here, do not present reality or rationalize. And number 3, always redirect with new activities like playing a game or walking. So let's break this down and tell you why. Well, studies show that with end-stage dementia, there's too much damage in the brain, making it impossible for clients to understand reality. And when you present reality, this causes more agitation and aggression, and even more anxiety. So interventions revolve around distraction and redirection to prevent this. So don't get tricked. These are typically the most trickiest questions here. So ATI mentions place personal items such as pictures at the client's bedside and provide a manual activity to occupy the client in order to prevent the need to restrain the client with dementia. Kaplan says, encourage the client to discuss those mixed up feelings. Guys, we're always acknowledging and discussing here. And Hesse asked a question about a patient in stage 3 Alzheimer's with aggression. And the answer was redirect by completing a crossword puzzle for distraction. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share Guillain-Barré's syndrome. Just think ground up berets. Since clients get rapid ascending paralysis, starting in the legs from the ground and up. Now this eventually reaches the respiratory system, which ends up killing the patient within a few hours or a few days. So think Guillain-Barré's as Guillain-Barré's. Go seek medical treatment immediately. Now, as far as the patho, it's an autoimmune disease where the body's own immune system is attacking its own nerves, usually triggered by an infection that's either bacterial or viral. And typically most patients won't even know they have GB until they get a really bad infection that triggers the immune system to fight, and that hyperimmune system ends up attacking its own nerves. Now, the key signs and symptoms to write down: ascending symmetrical muscle weakness, remember from the ground up, and then lower extremity weakness that progresses over hours or days, and then a big one to highlight here is absent deep tendon reflexes, which eventually leads to neuromuscular respiratory failure, which ultimately kills the patient. So please write this down because the NCLEX focuses on the most deadly signs for any disease. So for respiratory failure, the earliest signs is, write this down, inability to cough and the inability to lift head or eyebrows. Those two big ones came up multiple times on various question banks. And lastly, you have shallow respirations, dyspnea, and hypoxia. Now, respiratory always comes up first, so look for the keywords that deal with airway, like the ones listed above. So a common NCLEX question asks a priority finding with a client with Guillain-Barré's. So the inability to lift head or cough. Those big keywords there are very tricky. So don't get tricked on the NCLEX and know these key terms. Now for nursing interventions, we need to have an intubation set up at the bedside and mechanical ventilator ready. Kaplan had a question about priority for a patient with GB. We always prepare a mechanical ventilator for any client with worsening Guillain-Barré's. And for other treatments that weren't really mentioned by question banks, we can always use IVIG to help the body stop attacking itself and start attacking this IVIG substance. And also plasmapheresis, which is basically just plasma exchange. It filters the blood to remove antibodies that contribute to the destruction of neurons. But again, this wasn't highly tested, so just be sure to know the key terms that are mentioned above in terms of respiratory failure.
All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides.
Now for head injury, also called TBI, that traumatic brain injury, caused by any injury to the head, from a motor vehicle accident to falls greater than 20 feet, and even child abuse from shaken baby syndrome. Now the pathophysiology and signs and symptoms are pretty simple. We have both an open and closed head injuries. So for open TBI, we typically see a basilarity skull fracture, where we get broken bones at the base of the skull. Now the key sign to write down is CSF leakage from the eyes, ears, and nose, spinal fluid drainage. So the key terms they use is clear fluid drainage that is positive for glucose. This is indicative of cerebrospinal fluid. So Kaplan questions mention a client with a head injury with clear nasal drainage is noted. We have to check the drainage for glucose. And the second question was, which patient to see first following a mass casualty incident? And the answer was the patient with clear fluid draining from the right ear. This is a basilarity skull fracture, and this is a priority patient. Now for closed TBI, the skull is not fractured, so let the name help you here. The skull is closed. So we have concussion, which is a minor TBI from blunt force trauma, like when someone gets knocked out in a boxing match or even a football game. We typically see a brief loss of consciousness, which is a huge NCLEX tip since it's the most commonly tested, as well as headache and retrograde amnesia. Now, don't let the NCLEX trick you here. Not vision loss or pupillary constriction, and definitely not a change in mental status or projectile vomiting. These two are classic signs of deadly increased ICP, that swelling in the brain, which we cover in another video. Now for contusion, the major TBI, we have coup contra coup. So coup is blunt force to one side, like if you get hit in the head on one side. And coup contra coup is when the brain slams against both sides, both front and back of the skull, aka the frontal lobe and the occipital lobe. Kind of like whiplash in a motor vehicle accident, or that shaken baby syndrome. This causes bleeding, swelling with inside the skull, leading to increased ICP. So the key points to write down is frontal lobe injury will get expressive aphasia, that's speech difficulty, as well as memory problems. And for the occipital lobe, we will get vision problems. So the memory tricks we use to help you during your exams, just think the frontal lobe controls the front office, kind of like customer service in a hotel lobby. It controls speech, memory, and voluntary movement. Now the occipital lobe controls eye function. So just think ocular for occipital. We have sight and visual perception. Or just think of the O's in occipital. They kind of look like two O's for your eyes. And the other three regions, we have the temporal lobe, which is for hearing. So just think tempo, like you're hearing a beat, for temporal. And then the parietal lobe is sensory and touch. Just think of purring kitten as soft and fluffy to the touch for parietal. And then the cerebellum, just think cerebellence, since it controls the balance. And then lastly, we have the brainstem, which controls the heart rate as well as the respiratory rate. Now, two common NCLEX questions. What is the most likely affected by Coop-Counter-Coop brain injury? The answer is vision, memory, and speech, that expressive aphasia. Remember, both front and back, so the front office and the occipital lobe, that ocular vision, are affected. Not sensory function, that's the parietal lobe, which is the most commonly chosen wrong answer, and not hearing, that was the temporal lobe there. Now, question number 2, which assessment is expected with an occipital lobe injury? And the answer is deficits in visual perception. So remember, occipital, just think ocular for your eyes. Now, switching gears to hematomas. These are just a collection of blood outside the blood vessel, and we have 3 types. Epidural hematomas, which are the most deadly, subdural hematoma, as well as a subarachnoid hematoma. It basically just depends on which layer of the brain tissue is having the bleeding. Now, out of all these 3, the most deadly was that epidural hematoma. It's considered a medical emergency due to the high bleeding and rapid death from that increased ICP.
Now for some specific key terms and pathophysiology test tips. First up is hematomas. I'd be sure to write this down. Epidural, we see bleeding between the dura mater and the skull. Signs arise within hours. So as you know, the brain has 3 layers in the meninges, which line the brain and spinal cord. First is the dura mater. The second is the arachnoid mater, and third is the pia mater. So this is why epidural hematomas are the most deadly here, because this bleeding is between the dura mater and the skull. The second is subdural hematomas, bleeding between the dura mater and arachnoid mater. Now it's a little deeper inside the brain. So the CSF, the cerebral spinal fluid, may leak into the subdural space. And the last one here is the subarachnoid hematomas. This is bleeding between the arachnoid and pia mater. Blood mixes with CSF, that cerebral spinal fluid.
So the classic sign here is initial loss of consciousness followed by brief alertness, that regain of consciousness, and then here's the key, loss of consciousness again. Clients will say they feel sleepy and then ultimately slip into a coma and then die. So the top priority here is to stay with and monitor a client who passed out from a head injury but is now awake again, since blood can rapidly accumulate within the skull and increase that ICP, which can eventually push the entire brain to one side or even down the brainstem, causing rapid death since it turns off the drive to breathe.
Now for more patho test tips, be sure to write these down. The etiology, all hematomas can cause increased ICP, that increased intracranial pressure, a big key term to know for patho exams. Now other signs and symptoms to know, or manifestations, are seizures and autouria and rhinorrhea, where CSF leaks from the ears or nose, as mentioned before. And lastly, we also see a fever in certain clients.
Now, as far as interventions for any type of head or spinal injury, the first priority to write down is you must stabilize the cervical spine, also called C-spine. You have to keep that body in perfect alignment. So Kaplan states, a client with suspected head injury reporting dizziness, the nurse should first immobilize the neck. Then we assess the GCS, the Glasgow Coma Scale, frequently. So 15 is the highest score. Less than 8, we intubate, since the client will be in a coma, and then the lowest score you can get is a 3. And the key point to know here is you must report any type of decline in the GCS score. So write that down. Any type of change must be reported. So just think lower the score, lower into the grave you go, since it's more deadly. Now, 2 common exam questions here. Question 1, the client recovering from a head injury had a GCS of 15 over 2 hours ago. But now the GCS score is 14. What is the first action? So the correct option is to report to the provider immediately. Now, question 2 was, a client in C-spine after a fall, the priority assessment is to obtain the GCS, the Glasgow Coma Scale score. This is always typically done first, so don't get tricked. Not a head-to-toe full assessment. This comes later in the secondary survey. Then we monitor for that increased ICP, which we cover in detail in another video. But some quick key points to write down and just to know. Early signs of that increased ICP is agitation, the biggest NCLEX tip we can give you. Some question banks will call it restlessness or irritability, as well as change in LOC, that level of consciousness, decreased mental status, and then here's a key one, sudden vomiting, that emesis, without nausea. And then very late signs will see seizures, posturing with decorticate and decerebrate, as well as Cushing's triad as the brain gets crushed. So just think crushed vital signs with Cushing's triad as that brain stem gets crushed from all that increased pressure, which we'll cover in the ICP video. Now, common exam questions that get a little bit tricky here. They always ask about clients admitted for observation with hourly neurochecks as ordered. So we have to wake up the patient every hour and ask questions to assess that level of consciousness. The key term here is difficult awakening, since they can slip into the coma and never wake up. So you must be assessing for a level of consciousness and that change in mental status. That is what's priority here. Now, as far as diagnostics, we can do imaging like a CAT scan or an MRI to show evidence of bleeding, bruising, or swelling, but really the key points is in discharge teaching. So we teach return if the patient has difficulty walking, that ataxia. An adult should stay with the patient at all times to check those changes in mental status. And then obviously no alcohol, which is a vasodilator that can make the brain swelling worse. Now, don't let the NCLEX trick you here. It's not necessary for the patient to stay awake all night. The key here is to teach family members to monitor for changes in that mental status. It's very subtle, but it's critically important.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free